Hello learners, welcome to lecture 37. In the previous session, we discussed the role of education in child development and welfare. Today, we turn our attention to disability and inclusive healthcare for children, a topic that combines health, rights and social justice. Children with disabilities often face multiple barriers, including limited access to health services, stigma, and exclusion from education and community life. In this lecture, we will explore the burden of disability, challenges in care, and approaches for creating inclusive health systems that respect every child's right to health and dignity. Disability in childhood is both a public health issue and a human rights concern. It affects a child's ability to grow, learn, and participate fully in society. Inclusive healthcare goes beyond medical interventions to ensure equal opportunities, accessible environments, and dignity for all children. By framing disability as an equity issue, we recognize the importance of addressing systemic barriers that hinder children from achieving their full potential. Disability is defined by WHO as impairments, activity limitations, or participation restrictions resulting from interaction between health conditions and environmental barriers. Disabilities can be physical, sensory, intellectual, or psychosocial. Importantly, disability is not solely a medical issue. It arises from how society and environments respond to individual needs. Recognizing this shifts the focus from fixing the child to transforming systems and environments. From sociology point of view, this aligns with the social model and the UN Convention on the Rights of Persons with Disabilities. The problem is not the child, but the barriers, architectural, attitudinal, communicational, that restrict participation. Inclusive systems use universal design and for learning in schools. Reasonable accommodation in exams and clinics, and assistive technologies like screen recorders, hearing devices, etc., to enable agency. Intersectionality matters. Disability often compounds gender, caste, poverty, and rural disadvantage, so outreach, safe transport, caregiver supports, and cash transfers are part of equity, not extras. Governance should include disaggregated data and the representation of children with disabilities and caregivers in school management committees and local health bodies to ensure accountability. Ultimately, reframing disability from deficit to rights and capability turns services into platforms for participation, belonging, and dignified futures. Globally, more than 240 million children live with disabilities, though prevalence is often underreported due to stigma and lack of data. Low and middle income countries bear a disproportionate burden compounded with weak health and social systems. Childhood disability frequently goes undiagnosed or unaddressed, resulting in lifelong exclusion. These numbers highlight the urgency of inclusive policies and health services that address both prevalence and invisibility. Childhood disabilities arise from diverse causes. Congenital conditions such as cerebral palsy or congenital heart disease play a role, as do preventable causes like malnutrition, infections, and inadequate immunizations. Road traffic accidents, child labor, and unsafe environments also contribute. Poverty and lack of access to healthcare exacerbate risks and showing how structural inequities intersect with health conditions to create disability. These pathways reflect both biomedical insults and social production of risk, where gender, caste, poverty, and rural urban divides shape exposure, timely care, and long term outcomes. Prevention requires life course approach. Maternal nutrition and antenatal care, full immunization, water, sanitation, hygiene, injury prevention, and elimination of hazardous child labor. Early identification from newborn screening, developmental surveillance at Anganwadis and schools, and rapid referral paired with community based rehabilitation and assistive technologies can minimize impairment turning into disability. Equity levers like cash transfers, transport support, inclusive insurance, and reasonable accommodation in schools, clinics reduce the compounding effect of poverty and disability trajectories. Finally, participatory governance with caregivers and adolescents with disabilities in local committees ensures that environments become safer and services more responsive, shifting the system from episodic charity to rights based inclusion. Disability affects multiple dimensions of child development. Physical impairments limit their mobility and their independence. Cognitive challenges affect learning abilities, and stigma hinders social integration. Children with disabilities are often more vulnerable to illness due to poor access to health services. Additionally, exclusion from school and play reduces opportunities for growth. These barriers compound, leading to long term disadvantages unless inclusive approaches are adopted early in life. Stigma and discrimination both remain a powerful obstacle to children with disabilities. Negative attitudes in communities, schools, and health facilities often lead to exclusion. Families may hide children due to fear of social judgments. Discrimination reduces access to services, perpetuating cycles of neglect. Addressing stigma requires awareness campaigns, policy protections, and promoting narratives that celebrate diversity and inclusion. The UN Convention on Rights to Persons with Disabilities emphasizes the rights of children with disabilities to health, education, and participation on an equal basis with others. It affirms dignity, autonomy, and non discrimination. National frameworks such as Rights of Persons with Disabilities Act in India echo these commitments. Rights based approaches shift the conversation from charity to justice, demanding systemic accountability. This means removing architectural, attitudinal, and communication barriers and guaranteeing reasonable accommodation so that participation is the norm, not the exception. In practice, aligning CRPD and RPWD with universal design for learning in schools, accessible primary care, assistive technologies, and safe transport converts legal promises into everyday inclusion. Accountability requires child and disability disaggregated data, child friendly grievance redressal, time bound service standards, and budgets that specifically fund accessibility and support services. Participation must be real. Children with disabilities and caregivers represented in school management committees, health advisory boards, and local governates, so policies reflect lived experience. Finally, training of frontline workers on disability sensitivity and intersectionality, that is, gender, caste, poverty, or rural urban divides, ensures that dignity and autonomy are protected in day to day encounters, not just in statues. Inclusive healthcare means providing services that are physically, socially, and economically accessible to children with disabilities. It requires respectful care that values diversity and prioritizes equity. Inclusion goes beyond treatment, ensuring that children participate fully in their care and in the society. Inclusive healthcare challenges us to design systems that adapt to children and the other way around. Children with disabilities face multiple barriers to healthcare. Facilities may lack ramps, sign language interpreters, or adaptable equipment. Health workers often lack training in disability sensitive care. Costs of specialized services place an added burden on families. Social stigma further discourages families from seeking care. Inclusive healthcare must address these barriers systematically, creating supportive environments for children and families. Inclusive care demands universal designs, communication access, and reasonable accommodation during registration, examination, and follow up. Standardized disability sensitive training for clinicians and frontline workers, co designed with organizations of persons with disabilities and caregivers, shifts practice from charity to rights and dignity. Financial protection, for example, free diagnostics, transport stipends, assistive devices, and inclusive insurance, reduces catastrophic spending that deters care. Integrated referral pathways, linking Anganwadis, schools to primary care, rehabilitation, and tertiary services, supported by caste coordinators, case coordinators, prevent drop offs. Finally, community engagement to confront stigma, plus disaggregated data and clear grievance redressal mechanisms creates accountability to inclusive healthcare becomes the norm rather than the exception. Primary healthcare is the first point of contact of children with disabilities. It plays a key role in early identification through screenings and growth monitoring. Community based rehabilitation extends services to local contexts, empowering families and communities. Primary care also coordinates referrals to specialized services, ensuring continuity of care. Strengthening primary health systems is essential for making inclusive care widely available. Early identification of disabilities through newborn screenings, developmental checkups, and school health programs enables timely intervention. Early therapies such as physiotherapy, speech therapy, and occupational therapy can significantly improve outcomes. Addressing disability early reduces the long term burden to families and health systems and enhances opportunities for children to participate to their full potential in life. Systemic screening combats unequal access by ensuring every child, regardless of gender, caste, rural urban location, or disability, get the same chance at timely support. Practical steps include using standardized tools, clear referral pathways from Anganwadi and school screenings to primary care and rehabilitation. And of course, family centered plans that coach caregivers in home based simulation. multidisciplinary early intervention centers, which have services like physiotherapy, OTs, speech language therapies, psychology counselings, linked to inclusive early childhood education, prevent minor delays from becoming entrenched disabilities. Financial protection of free diagnostic, travel support, and subsidized assistive devices reduces dropouts due to cost. Finally, tracking outcomes with disaggregated data and regular case in reviews creates accountability. So, early identification reliably translates into participation, learning, and dignified futures. Rehabilitation is a central component of inclusive care. Physical and occupational therapies improve mobility and daily functioning, while speech and language therapy enhance communication. Beyond medical support, rehabilitation also addresses social reintegration, ensuring children can attend school, participate in play, and engage in community life. Comprehensive rehabilitation bridges health and social inclusion. Inclusive education and health are closely linked. Schools that include children with disabilities normalize diversity, reduces stigma, and build acceptance among peers. School based health services such as therapy sessions, counselings, or screenings bring care closer to children. Integrating of education and health ensures that children with disabilities access both learning and care in supportive environments. Families are central to the well being of children with disabilities. Parents and caregivers provide daily care and advocate for their child rights. However, they often face emotional stress, financial strain, and limited support. Training families in home based therapies, offering counseling, and providing social support are crucial for empowering them. Family involvement ensures sustainability of care and nurtures resilience. Communities can either reinforce stigma or become sources of support. Inclusive communities provide networks that reduce family isolation, promote participation, and change cultural attitudes towards disability. Community based programs encourage acceptance and create inclusive environments in school, workplaces, and public spaces. Building community ownership is critical for long term inclusion of children with disabilities. Assistive technologies empower children with disabilities to participate more fully in life. Mobility aids, hearing aids, and communication devices enhance independence, education, and social interaction. However, affordability and accessibility remain major challenges in many countries. Ensuring provision of assistive devices through public health programs is an essential step towards inclusive healthcare. Training health workers in disability sensitive care is crucial. Professionals must recognize the rights and dignity of children with disabilities, adapting care to their needs. Training enhances empathy, reduces bias, and builds trust with families. Without such training, even well intentioned services may fall short. A skilled, sensitive workforce is the backbone of inclusive healthcare for children with disabilities. NGOs and civil society organizations are instrumental in disability inclusion. They provide rehabilitation services, advocate for rights, and raise awareness in communities. NGOs often pioneer innovative models that government later adopts. They also influence policy by highlighting gaps and pressuring for stronger enforcement. Collaboration between state and civil society enriches inclusive health services. In India, government programs address child disability through integrated approaches. The Rashtriya Bal Swasthya Karyakram (RBSK) screens children for disabilities and provides early intervention. Sarva Shiksha Abhiyan promotes inclusive education, ensuring children with disabilities attend mainstream schools. The Rights of Persons with Disabilities Act strengthens legal protections. Together, these programs reflect a growing commitment to inclusion. Building on this, RBSK links schools' Anganwadi screening to district early intervention centers for multidisciplinary care, assistive devices, and caregiving coaching so detection leads to action. Inclusive education, now under Samagra Shiksha, operationalizes universal design for learning, resource rooms, reasonable accommodation in exams, transport, hostel support, and teacher training to keep children in neighborhood schools. Convergence with programs like ICDS, primary health care, and social protection reduces the cost burden that often drives dropouts. Gender, caste, poverty, and rural urban divides are lessened. So, outreach, safe transport, and community based participation are targeted to the most excluded. Finally, child and disability disaggregated dashboards, school management committee participation by caregivers, and time bound service standards create accountability, turn legal promises into everyday inclusion. Globally, UNICEF advocates for inclusive education and health, focusing on equity and participation. The WHO Global Disability Action Plan calls for strengthening health systems to meet the needs of persons with disabilities. The Sustainable Development Goals emphasize leaving no one behind, explicitly recognizing disability inclusion. These global initiatives align national policies with international commitments to child rights and equity. Disability rarely exists in isolation. It intersects with poverty, gender, and geography. Children with disabilities from poor families face compounded disadvantages. Girls with disabilities often experiences double discrimination, being excluded both as females and as disabled persons. Rural areas lack services compared to urban centers. Intersectional approaches are necessary to address these overlapping inequities effectively. Ethical considerations are central in disability care. Respecting autonomy and dignity means involving children where possible in decisions about their care. Informed consent tailored to developmental capacity ensures that rights are upheld. Balancing medical care with individual rights prevents paternalism. Ethical frameworks remind us that children with disabilities are not passive recipients but active right holders. Education plays a transformative role in inclusion. Schools that integrate children with disabilities foster acceptance among peers, normalize diversity, and provide equal opportunities. Inclusion in education breaks cycle of stigma and exclusion, equipping children with skills for independent living. When combined with health services, education becomes a powerful tool for advancing both development and dignity of these children. Excluding children with disabilities has far reaching social implications. It isolates children and families, denying them community participation. Society loses valuable human capital when children are denied education and health. Exclusion perpetuates inequality, reinforcing cycles of poverty and marginalization. Inclusive systems not only benefit children but also strengthen societies by harnessing the potential of all members. Exclusion is socially produced through architectural, attitudinal, and communication barriers, and it erodes social cohesion as much as it depresses economic poverty. Right based inclusion reframes children with disabilities as rights holders and contributors, calling for universal design in schools and clinics, reasonable accommodation, assistive technologies, and safe transport so participation becomes the default. Equity requires tackling intersectionality via scholarships, caregiver supports, and community based rehabilitations to prevent dropouts. Accountability tools, child friendly grievance redressal systems, disaggregated data, and time bound service standards ensure promises convert into access and outcomes. Finally, co production with children and caregivers in school management committees and local health boards builds trust and designs solutions that work in real community contexts. Children with disabilities are particularly vulnerable in emergencies, facing barriers to accessing relief, shelter, and health services. Inclusive health in emergencies requires ensuring accessible facilities, targeted support, and dignity in response efforts. Planning must include disability perspectives to avoid deepening inequalities. Emergencies highlight the importance of resilient, inclusive systems that protect the most vulnerable. The future of inclusive child health care lies in scaling up early intervention, ensuring universal access to assistive technologies, and integrating disability perspectives into all health policies. Strengthening data systems to capture disability prevalence is also essential. Future strategies must be right based, inclusive, and sustainable, creating health systems that truly serve all children. To summarize, childhood disability is both a health challenge and a right issue. Inclusive healthcare focuses on removing barriers and creating enabling environments. Families, communities, health workers, and governments must collaborate to ensure equity. Disability inclusion is not optional, it is essential for achieving health and development goals. Early, every child needs early intervention, access to services, and the opportunity to thrive. In conclusion, inclusive healthcare for children with disabilities is transformative, enabling them to live a healthier, more fulfilling life while enriching societies. Exclusion not only harms individuals but weakens communities. By embracing inclusion, we affirm that every child matters, every ability has value, and every life deserves dignity. Inclusive healthcare is a cornerstone of both public health and social justice. Thank you. This is all for today's lecture. And in our next lecture on lecture number 38, we'll deal with impact of child labor on health and development. Thank you.